Good morning, good afternoon, and good evening, everybody. Welcome to the country consultation on the Alliance for Anemia Action. My name is Marty van Lieren, and I work with the Micronutrient Forum. As an introduction, addressing anemia is foundational for empowering women, their families, communities, and nations. More than 1 in 3 women suffer from anemia globally. That results in increased risk of infections and death, lower cognition, extreme fatigue, poor pregnancy outcomes, loss of earnings, and poor growth and development for babies and children. Prior to COVID-19 pandemic, no country was on track to meet the global World Health Assembly targets for anemia reduction by 2025. And now, with the COVID-19 impact, there is an estimated additional 4.8 million women that will be impacted by anemia by the year 2022. So achieving rapid progress in the coming decades is really needed. And this will require coordinated and accelerated, as well as the right actions specific to the country's anemia context. And we need a diverse set of stakeholders across sectors. Now, the Alliance for Anemia Action is a UN food system solution that brings together the food, health, social protection, and environmental sectors to accelerate progress in science, policies, and programs to achieve the SDG 2 anemia reduction target. This alliance provides a platform to learn from countries and leverage the experience and expertise of leading initiatives on anemia reduction. By driving a dynamic research and learning agenda, we may be able to use to connect evidence to be more impactful and get context-specific actions through multiple sectors. Now, I have a couple of practical points for you, the participants. First, this session has simultaneous translation from English to Spanish and French. I probably should have started with that, so you could have heard my introduction in the right language. You see an interpretation button at the, I would say, the bottom right of your screen, and you can choose the correct language there. Then I would like to ask the participants, if you have questions for the speakers, please write them in the Q&A. So only questions for the speakers in the Q&A. For any other information, if you would like to introduce yourself or share other comments, please use the chat function. And then, without further ado, I actually would like to introduce to you the first speaker. This is Saskia Ozendar. Saskia is the Executive Director of the Micronutrient Forum. She is also an Associate Professor at Wageningen University and a co-lead in the Standing Together for Nutrition Coalition, and also one of the initiators, amongst more, for this Alliance on Anemia Action. So without further ado, Saskia, I'm handing the floor to you.
Yes, thank you, Marty, and welcome everyone. Gurmit, the first slides, please. Can you move to the second slide already? Because before I will inform you more about the Alliance for Anemia Action's proposal, I would first like to take a step back and look in more in depth to the problem of anemia. And Marty already alluded to this, because anemia really is one of the most striking manifestations of poor women nutrition in the world. We know that more than 1 in 3 women globally suffer from anemia, and this results in increased risk of infections and death, lower cognition, extreme fatigue, poor pregnancy outcomes, loss of earnings, and lower growth and development for the babies and children. And we also know that the COVID pandemic has really added to this challenge. We knew, and you've heard that from Marty, that prior to COVID, already no country was on track to meet the global targets for anemia. But due to the pandemic, the Standing Together for Nutrition Consortium estimated that an additional 4.8 million mothers are expected to become anemic by the end of 2022. And we do have evidence-based, effective, and affordable and cost-effective solutions available. And we know that with every $1 invested in anemia, we will receive a $12 returns in improved health and productivity. So we really need to tackle this lack of progress. And as Marty said, we know that so far our progress has not been sufficient. So we need a radical change in approaches that cannot be addressed without collaboration across sectors. So this new approach, therefore, will unlock impact that has been constrained by these programs that have taken place in silo and by insufficient attention also to the multi-sectoral nature of anemia. And in addition to that, we also need to achieve a more rapid integration of new data, of new evidence, lessons learned, and policy recommendations across sectors and into effective programs and policies. So this cross-sector Alliance for Anemia Action has been proposed now as one of the game-changer solutions developed for the UN Food Systems Summit, but really with a strong need to move further and develop and be launched at the Nutrition for Growth Summit. We know also that women bear the highest burden and they have the highest nutrient requirements, particularly during pregnancy and lactation, and because they often eat last and least. So actions to overcome anemia, therefore, should be considered an equity issue and should have women's empowerment really at its core. And it's therefore very appropriate that this game-changer solution of the Alliance for Anemia Action has been included in and integrated in a cluster proposal for the preparations of the UN Food Systems Summit around women nutrition, empowerment, and leadership. And I will briefly describe that cluster proposal to you in a minute. And there will be another affiliated session organized as part of the Food Systems pre-summit that will take place at the last week of July, later this month. And the session will take place on the 27th of July. Next slide, please. So the Alliance for Anemia Action aims to really accelerate the reduction of anemia in women of reproductive age and children across the globe to achieve the target of a reduction of 50% by 2030. And it will do so by bringing together stakeholders across disciplines, sectors, and geographies. And while the Alliance was initiated globally with global and country stakeholders, eventually it will be country-led and globally supported, and it will include a robust accountability framework. So the Alliance really commits to developing a global anemia action plan that is based on this integrated food and health systems approaches that will be responsive to specific contextual needs. And this will guide the development of national anemia action plans by early riser countries. It will also develop an integrated research and learning agenda to address the remaining evidence gaps, for instance, in the biological context, in diagnostics of anemia, as well as implementation science and programmatic issues that all constrain progress in anemia reduction. And it will share the lessons learned and provide a platform to facilitate a more rapid integration of new evidence and learnings into effective programs and policies. And it will develop an investment strategy that will unlock funding and will encourage more governments and multi and bilateral donors to invest in the implementation of these integrated actions for anemia. Next slide, please. So this is how it should work in practice. We know that this lack of progress is because anemia is a very complex, multi-causal health issue, and that these causes can vary by context. So the radical new approach that is proposed by the Alliance is to start from an in-depth analysis of the context-specific multi-causal etiology of anemia, including an identification of evidence gaps, and then based on this analysis, develop a context-specific, multi-sectoral and adaptable plan of action in which cross-country and cross-sector coordination and collaboration will accelerate anemia reduction beyond the impact of parallel programmatic approaches in silo. We know that poor quality diets that deliver insufficient iron and other micronutrients are really an important cause of anemia, but not the only cause. But it is therefore for the Food Systems Summit that the focus will be on food systems actions that include the, improving the access and the availability of nutrient-rich foods, such as animal source foods, eggs, and but also legumes and fruits and vegetables, as well as the fortification of staple foods and condiments with micronutrients and biofortification. But in addition to that, supporting health and environmental sector interventions are also required simultaneously. And this includes the control of infections and inflammations and infectious diseases such as malaria, because these are important other causes of anemia, but also the control of hemoglobinopathies such as thalassemia in regions where these are very common. And in addition, women during pregnancy and lactation need iron-containing supplements to complement their diets and improve pregnancy outcomes. And these needs to be delivered through antenatal care. And we also need to include actions to improve women empowerment, women economic empowerment, to make sure that women really have the ability to consume healthy diets and get the adequate care that they need for themselves and their families. Next slide, please. So while the actions for the actions for improving anemia are important, we embed this for the purpose of the Food Systems Summit in a cluster around women economic empowerment and leadership as well, because we know that actions for gender equitable food systems really require systems change at different levels. And we have chosen 3 more vital elements of gender equality in food systems around nutrition, economic empowerment, and leadership to work on this. And just to briefly describe to you the other 2 pillars of this cluster proposal, there's one on women's economic empowerment, because we know that this benefits gender equality, it benefits nutrition, and it benefits the economy. And the specific entry point here are hubs that are designed to support women-led enterprises generating income through production and value chain activities. The second initiative in this cluster proposal is an initiative to measure the accountability, because we know that women's voices are typically missing from decision-making processes in the food system, reducing the opportunity to pay greater attention to gender equality. And we know that in order to make progress on all these aspects, we need to be able to measure and hold people accountable. So an initiative called the Global Food Systems 50/50 reporting mechanism will create accountability for food systems organizations and actors to appoint women as leaders and to have gender responsive internal policies. Next slide, please. So these are the tactics and deliverables that the countries and global partners combined in the Alliance will work on towards UN Food Systems Summit and eventually to the launch of the Alliance at the Nutrition for Growth Summit. We will discover new evidence and share learnings more effectively for effective actions through this integrated research and learning agenda. We will foster global and domestic investments in anemia reduction by the development of an investment strategy. And we will develop a global anemia action plan, which will include a communication and advocacy strategy and a strategic approach and roadmap to put existing program and policy recommendations into practice and to address knowledge gaps. And the Alliance will work with global partners and they will be contributing to the Global Anemia Action Plan and eventually seek commitments from early riser countries to holistically address anemia and develop these national integrated anemia action plans. And we know that this is important because we have not made sufficient progress. And more importantly, we know that an investment in a 50% reduction in maternal anemia is estimated to bring a total of more than 110 billion US dollars in total economic benefits for low and middle income countries over 10 years, as has been shown in the World Bank Investment Framework for Nutrition. So we really need to come together and mobilize these sector-specific commitments. And I'm looking forward to the inputs in this country consultation from the countries on how we can drive these Alliance for Anemia actions forward. Thank you very much. Over to you, Marty.
Thank you, Saskia. And I will now, for these introduction moments, a short description on the Alliance. What we will now do is go to our first panel with the moderator and the 3 panelists that I will introduce. And then I'm asking the moderator and the panelists to put on their cameras and their mics at the same time. So Lynette Neufeld, the Director of Research and Knowledge Leadership, will be moderating this panel. Lynette works at the Global Alliance for Improved Nutrition. And we have 3 panelists from 3 countries. The first panelist is Dr. Sutapa Neogi. She is the Dean of Research at the International Institute of Health Management Research in India. The second panelist is Dr. Selene Pacheco, a researcher at the Program and Policies Nutrition Research Department of the National Institute of Public Health in Mexico. And our third panelist is Richard Pandame. He is the Regional Director for Africa of Nutrition International, and Richard is based out of Kenya. So please, all panelists and moderator, turn on your indeed your videos. I will mute myself and go offline. And Lynette, the floor is yours.
Thank you very much. I'm very happy to be here and very happy to have our 3 panelists here today. I would like to just a little point of process to just let you all know that during the intervention from Dr. Pacheco from Mexico, we will be having that discussion in Spanish. So just to let you know, if everyone can find the little interpretation button on the bottom sort of central right corner of the screen, as was mentioned, there's also instructions to access that interpretation in the chat box if you need some help with that. So again, welcome everyone. Very excited to hear. During this first panel discussion, we're going to hear from 3 country representatives who have been working on programs to address the challenges of anemia. So during this first panel, we're going to hear about those programs. I'm going to ask each of them to speak for approximately 5 to 7 minutes about 5 minutes, perhaps more like 5 minutes, describing the program. Tell us a little bit about it. Tell us about how that approach is set up, some of the achievements that have been gained, a little bit about the financing of the program, if you'd like. And then we'll come back and we'll take some questions and we'll have some discussion as a group, okay? So we're going to start with India, and our colleague from India will share a few slides. So I think if the other 3 of us go off video for the first few moments, I will pass the word over to you, Dr. Neogi, and we look forward to your intervention. Can you please put the slides for India up? Thank you.
Yeah. So very good morning, good afternoon, good evening to all the participants in this meeting. I bring greetings from India. So I'll be briefly telling you about the program that we are having for anemia control in India. It's not that we have started thinking about anemia recently, but we have been having some or the other program for anemia control for the last 40 years or so. Of late, the latest in that series is Anemia Mukt Bharat program, which is a flagship program of Government of India. And the literal meaning of this is to make India anemia free. So Anemia Mukt Bharat stands for Anemia Free India. This, I would say, is an ambitious flagship program and is very different from the previous programs that we have had in the past 30, 40 years, in the sense that there are targets laid down in the program. So launched in September 2018, this program aims to reduce prevalence of anemia by 3% across all the age groups. And when I say all the age groups, I'll be explaining to you when I explain the 6x6x6 strategy. So in order to achieve those targets, the strategy which has been adopted by Anemia Mukt Bharat program is called the 6x6x6 strategy. So can I have the next slide, please? So the first 6 in this series stands for the beneficiaries, 6 beneficiary groups, which means that we are not focusing only on pregnant women only on children, but in fact, it encompasses the different age groups, which is children less than 5 years, 5 to 9 years, 10 to 19 years of adolescent age group, the pregnant woman, the lactating woman, and women of the reproductive age group, which means that we have an estimated 450 million beneficiaries who are supposed to be reached through this program, which covers almost 50% of the country's population. So you can imagine the quantum of the work that is supposed to be done. Next slide, please. So this takes care of the first 6. The second 6 indicate the 6 interventions which are laid out. So first is the prophylactic iron folic acid supplementation, which has been going on for so many years now. But apart from that, we have an element, a component, which includes periodic deworming of children, adolescents, and women of reproductive age group. It is done in the form of a campaign, means it's done in a campaign mode. The third is the intensified year-round behavior change communication campaign, which includes ensuring delayed cord clamping. The fourth one is the testing of anemia and point of care of treatment. And fifth is the mandatory provision of iron and folic acid fortified foods in public health programs. And then, of course, India is very huge and diverse. So there are some pockets where, apart from nutritional causes, there are other non-nutritional causes, which are actually the major causes of anemia. And for that, we have special programs and schemes to tackle those causes of anemia. So this takes care of the second 6. Next slide, please. And the third 6 is basically the most important of all among all these 3 6s, which includes the implementation mechanisms on how we can achieve the target of reducing the prevalence of anemia by 3% every year. So the first in this is the intra-ministerial coordination. Intra-ministerial means anemia obviously has got a multifactorial etiology. And then if you have to focus on all the causes, it requires a good amount of coordination between the ministries and between the departments within the ministries. The second is National Anemia Mukt Bharat Unit, which has been created at the ministry. The National Center of Excellence and Advanced Research on Anemia Control, which has been set up at AIIMS, New Delhi. Another important challenge, yet important task, which is in front of us, is convergence with other ministries, which is difficult, I agree, but this is the requirement if you want to achieve those targets. Then strengthening supply chain and logistics, we have made a lot of progress on this in order to ensure that iron tablets, etc., they reach the primary care facilities and the community at the right time in right quantities and amount. And then we have the Anemia Mukt Bharat dashboard and digital portal, one-stop shop for anemia. This has been a great success in our country in the sense that now we can actually track every state, every district, even every block to see how those blocks or communities are performing in terms of anemia control. The issue is that it depends largely on the data which is collected routinely, and hence there are chances of biases and errors. And that is why, I mean, it is not taken so seriously by people in most of the cases, but then something is better than nothing. So here I would say that at least we have been able to create that kind of a system so as to capture data from the ground level and put it up on the website, which can be seen and visualized by all. Next slide, I think it's all. Okay, so yeah. So when I say that the multi-sectoral coordination or intersectoral coordination, a large depends on the causes of anemia. And it is for this reason that we are having a lot of emphasis on how to create a kind of convergence between different departments. So I'll elaborate more in my next panel probably. So I think I should stop here. Thank you.
Thank you. That was very, very informative. It's really quite interesting to see the 6 by 6 by 6. It makes for a very clear and concise communication of both what you're trying to achieve and also the approach by which you're achieving it. I really enjoy that. If I can ask 3 small clarifications, because I think it's going to be easier for us to stay in the Indian continent for a moment, and then we'll fly over the world over to Mexico. But for now, let's stay in India. And I want to ask first about, it caught my attention that you have highlighted both adolescent boys and girls. There was also a question in the chat about adolescents, anemia in adolescents, and explicitly about boys and girls. Can you tell me a little bit about the information that you had and the motives for including adolescents specifically, and then including both boys and girls, which is quite unique compared to other countries and other contexts that I've seen?
So when we say anemia, we are not focusing only on the pregnant woman as the outcome. It's to take care or tackle anemia in the population in general. So in the adolescent age group, there is no differentiation between boy and girl. It is a universal program which is made available to everybody, and it's been going on for quite some time now, I think some 5 years or so. And through the school health program, every adolescent receives 1 tablet of iron on 1 day in a week, and that is given to all. So that is a kind of modality which has been tried out initially in few districts, and now it has been scaled up across the country with a lot of success.
Okay, thanks. And so maybe I'll just, one other thing instead, just in the interest of time. Tell me a little bit about the institutional arrangement and the extent to which both academia and the implementation arms of the program come together, and a little bit about how that integration, because there seems to be a lot about evidence and data, and how does that integration with academia and implementing bodies of the government come together?
Okay, so if you recall that one of the mechanisms in the third success was to have a National Anemia Mukt Bharat unit, which has been set up in the ministry. And the prime function of that unit is to bring the academia and programmatic arms together. The second thing was that to create the National Center of Excellence and Advanced Research at AIMS. That is a perfect example of how an academia can be involved in programmatic research. And as part of that center, they primarily work on generating evidence on anemia, control, prevention, management, etc. But the nutritional part of it is taken care of by some other academic body, which is the Lady Irwin College. So there is a kind of an attempt to integrate the different organizations which are working in their own areas and bring them together at the ministerial level so as to create that kind of a convergence. And the same things are being encouraged by the states to do also. But states so far have not been able to, demonstrate that kind of a convergence, which is seen at the ministerial level, of course. But then there is, sufficient time left now for us to show that, okay, that kind of convergence is possible.
Okay, great. Thank you so much. Very, very interesting and informative. And we are going to switch over to Mexico. So all of those of you who don't speak Spanish, please do go to interpretation.
So Dr. Pacheco, I'm going to switch to Spanish as well. Could you tell us a little bit about the program in Mexico? And if you can keep your intervention to under 5 minutes, that would be great. And then we're going to have a brief Q&A. Thank you. Well, good morning. As Marty was saying, I'm a researcher at the National Institute of Public Health, which is an academic organization that advises the Secretary for Health in designing, implementing, and assessing programs and policies to improve the nutritional state of the Mexican population. So the main program that we have in Mexico to help control anemia in women in reproductive age and children under 5 is called Prospera, which is a conditional nutritional transfer program that is run at a large scale and was run for over 20 years between 1997 and 2018, until there was a change in our national government and the program was discontinued. However, during these 2 decades, it had a coordinated and systematic support of several different government bodies, such as the Secretary for Social Development, Secretary for Finance and Public Lending, Secretary for Education, and for Health. However, the Secretary for Health and Social Development were the key bodies supporting the program. The program seeks to improve the health and nutrition conditions of those households in extreme poverty, more specifically, pregnant and breastfeeding women and children under 5. What we did in the program was to provide reproductive and breastfeeding women with fortified meal-based drinks with high caloric and sugar content, as well as fortified baby food for all children. We also conducted several effectiveness assessments through random group trials in order to determine their impact. And what we found was that there was a very positive result, especially at the beginning, and that after the first 10 years, the results started showing a poor improvement in anemia. So we modified what we were doing, because what we were noticing was that although there was a high intake level of all these supplements and good distribution among families, the results were not as good. What we did was take note of all these findings, as well as the nutritional transition that we were undergoing in our country in 2013. And we modified what we were supplying to this population. So we started supplying pregnant and breastfeeding women with micronutrients tablets, as well as a milk-based drink that was fortified to children. And what we found with this new change was that between 2016 and 2017, there was a high intake of the micronutrients tablets among women in reproductive and breastfeeding age, and that in children under 5 between 2014 and 2015, there was an improvement of around 11% in the anemia levels for the children in around 11 states in the country. We believe that the country had such big results and that the program was conducted for such a long period of time because of the positive results that we were having in improving the nutritional status of our population, as well as the transparency in announcing targeted groups, as well as in delivering support. Well, thank you very much. It's very interesting to hear what you're sharing, especially because it is a model that is very different to the one that was being described in India, especially regarding the integration of specific nutritional goals that are combined with a social protection program. And I think that that is one of the biggest strengths in the program. But also, it became its weakness, because when the government decided to stop the program and discontinue this social welfare support that was being provided, that affected the program and put an end to it. So if you could tell us a little bit about the challenges you're facing nowadays, perhaps very briefly, and see how you can carry on working on this. Well, the program had 3 key elements: education, nutrition, and health. What I described a moment ago were all the actions specific to nutrition. But when the program was discontinued in 2018, this was very much related to the transition towards a new government. And what we are seeing nowadays is that there's a great need to create a similar program. So we are working with the Secretary for Health to identify the actions that were geared towards improving nutrition in pregnant women. And now we are working towards designing a similar program in the future that includes nutritional support and supplements for pregnant women and children during the first 1,000 days of life. So we are doing plenty of advocacy. We're trying to determine the impact of these policies and see whether we can take them up again. Well, thank you very much. And also, you mentioned that one of the determining factors for the success of this program were the positive results. So this means that the program was continuously assessed. Yes, the program was continuously assessed, especially to identify its impact on the nutritional status of the target population, such as pregnant and breastfeeding women and children under 5. But we were also carrying out assessments and evaluations of its efficacy and its implementation. So that's how we could identify some lessons learned from the program, especially related to its implementation. And I'm going to talk about this later on. Well, thank you.
Al contrario.
Okay, so let's switch back to English and travel to Kenya. Dr. Kendame. There you are. Okay, please tell us a little bit about the program in Kenya in approximately 5 minutes. We're looking forward to your comments. Thank you.
Thank you, Lynette. First, I would like to thank the organizers for giving me the opportunity to be one of the panelists at this very important meeting on the country consultation meeting. Maybe before I go to the anemia program, let me take the opportunity more to introduce myself and how my relevance sitting on this panel. I come on this panel to share my experiences gathered over 15 years working in Ministry of Health in Malawi, and 6 of which I served as permanent secretary, and another 15 years working in international development in sub-Saharan Africa, focusing on maternal, child, adolescent health and nutrition programs. I have been with NI for 10 years, leading to overseeing NI operations in Africa. About NI, for those who are on this webinar but don't know about Nutrition International, Nutrition International has almost 28 years working in fortification, child survival programs, and 10-year plus experience in maternal and newborn and child health nutrition. Over the last 5 years, we've been embarking on working on adolescent nutrition. And our work involves helping government design and scale up evidence-based nutrition programs and integration of nutrition interventions into health systems, including more recent experience with supporting SAN countries in the sub-Saharan Africa and Asia in multi-sectoral nutrition planning, resource mobilization, monitoring and evaluation. On the Kenya National Anemia Program, there is no anemia program as such, as is the case with other vertical programs such as malaria, TB, immunization, HIV, and AIDS. Since 2012, anemia is planned as part of the country's 5-year national and sub-national nutrition multi-sectoral plans. The sub-national action plans contextualize the national action plans. In terms of coordination, anemia control responses is coordinated within the SAN multi-sectoral coordination framework. The Nutrition Interagency Coordinating Committee, which is chaired by government, has ensured a coordinated planning and implementation of actions around anemia control. Within these structures, all nutrition stakeholders have clear role and responsibilities for anemia control efforts. And these sectors, namely, are agriculture, health, environment, academic research, education, and the private sector. In the health sector, anemia interventions are integrated into antenatal care, maternal newborn health and nutrition, malaria, HIV/AIDS control programs, as well as laboratory services. To measure progress against anemia and other nutrition indicators, Kenya has incorporated a monitoring and research, as well as information management and sharing. Kenya is one of the few countries in the region which has a nutrition scorecard, which is updated quarterly. And included in the scorecard are indicators for anemia response. In terms of achievements, I think with improved advocacy, anemia is recognized as the commonest and most intractable public health problem, and it is understood that it requires integrated and multisectoral approach. Second, the multisectoral approach to implementation of anemia reduction measures ensures that all stakeholders are involved in addressing all aspects of anemia reduction. Special mention should be to the Kenya private sector involvement, which has greatly improved access to fortified foods in Kenya. And of course, to the East Africa region. The third is country ownership has ensured the following: national food and nutrition policy in place, guiding stakeholders on the response to anemia. Positive policy changes have happened where it involves free government actually declaring maternity and child health, health and nutrition services to be free, which has greatly improved access to and demand for essential health and nutrition services for pregnant and children, and pregnant women, children and adolescents. Kenya's adoption of the UHC and prioritization of primary health care and nutrition in the UHC is also another policy that is positive in the drive to control anemia and nutrition in general. The national and subnational governments have actually increased their funding for nutrition by extension for anemia and improved human resources for health, resulting into improved access and availability of nutrition services, especially in rural areas. Though Kenya is not on track to achieving the global anemia target, Kenya has made notable improvement in the last decade. There are challenges still being faced. One, quality of care and programs. Second, data gaps that do exist. Thirdly, inadequate financial resources for supplies and data collection, and insufficient community engagement to increase access to services and to overcome traditions and taboos. That's, I can stop here, maybe unless you would like me to cover on what key lessons and challenges would be relevant to the Alliance. Over to you, Lynette.
Thank you very much. I think we can come back to the lessons and the Alliance in a moment. I wanted to just pick up, sorry, sorry, my buzzer going off here. I wanted to just pick up on two things very quickly. One is you mentioned a scorecard, and that I think is quite an interesting element in this, particularly given the many sectors that you mentioned. But I'm wondering if that scorecard is sort of led from within one sector, just to sort of to consolidate and to follow through on the implications of what you find in that scorecard. So can you just speak a little bit to that, sort of where does that scorecard sit, and who helps move forward any implications that come out of the results of tracking?
The scorecard is actually adopted by the SUN movement. It's coordinated by the Ministry of Health. The SUN coordination is actually under the Ministry of Health. So even the leadership of that SUN group in Kenya is actually by a senior government official from the Ministry of Health. It actually includes all sectors in actually trying to make sure that they're actually improving on all nutrition components related to the nutrition response.
Okay, great. And the other element I wanted to pick up on, you mentioned the subnational as well as national plans. Can you speak a little bit to that? Does that imply that the scope of activities is being planned at a subnational level such that different regions may have different sets of activities depending on the nature of anemia or the nutrition problem in that region?
Thank you very much, Lynette. Actually, the first year of the multi-sectoral planning for nutrition, which started in 2012, the first plan, which was the National Nutrition Action Plan covering the period 2012 to 2017, was actually planned only at national level. So we had only national integrated multi-sectoral program or plan, action plan. At the end of 5 years, it was realized that while we had a national plan, implementation was actually affected. And therefore, the country made a decision to say, once a national action plan has been developed, that action plan should actually be contextualized at country level. So each country looks at the main targets that have been set at the national level, and also they look at which of the issues are real issues in the county government. I think Kenya is also lucky that it happens at the same time there is a new constitution in Kenya where it is decentralizing public services to the county governments, and there are 47 county governments. Even us as Nutrition International, we support the national programs or the national action plan in terms of guidelines, in terms of policies, and in terms of monitoring. But much of the programming implementation is actually done by the county because they are the ones who have actually the support. And we've been doing advocacy in terms of improved financing for nutrition. In actual fact, we are pushing for government to actually mobilize their own resources and start funding anemia and funding nutrition. And even our way of working with the government is they put in money, we also put in money as part of matching and performance management of the programs.
Okay, wonderful. Thank you very much. We will, lots of food for thought, and we're going to be coming back to many of those points in the next panel. But before we do move to that panel, I would like to introduce Dr. Francesco Branca. He is the director of the Department of Nutrition and Food Safety at the World Health Organization based in Geneva. And he is going to provide us a few reflections on the country experience that we've been hearing about. Welcome, Francesco.
Good afternoon, Lynette and colleagues. A pleasure to be with you today at this important meeting. So, well, I'd like to give you 3 key messages. The first one is that success stories exist. I think we are all encouraged by successes, and I think we are now able to document some success stories on the elimination of severe anemia, on the reduction of anemia overall. The picture overall is not encouraging because we are not on track to achieve the target, but there are some success stories. There's a very interesting project led by the Hospital of Sick Children on exemplars, success stories on anemia. I think we're going to learn a lot about those success stories. I think we're also learning a lot from the experience of the practitioners, and I really would like to call everybody's attention to the initiative that has been led by WHO for a number of years called Accelerating Reduction in Anemia Effort in collaboration with USAID. It's a network of 800 professionals, and I can tell you we're learning every day good lessons. Second point, okay, the lessons that we're learning, and I really thankful to the three panelists who've given us such useful insights on the anemia programs of India, Mexico, and Kenya. What are, to me, the lessons learned? First of all, anemia reduction is a long-term undertaking. If you stop, it will collapse. So it has to be, we have to factor in the sustainability of the initiative. Second, it has to be multi-pronged strategies. It has to be on health, on food sector, on environment, absolutely. Third element is, this is to be done at scale. We need to make sure that the coverage is complete, and we need to make sure that we have good quality programs. We need to reach all those in need with adequate interventions, and we need to be concerned about how to do that. What kind of delivery platforms to do that? Health services, are they enough? Probably not. And then finally, data matter. Data to establish targets, and targets are extremely helpful there. Data to monitor the situation, and data to develop investment cases. And my final point is about, okay, what do we believe that should be done, and what is the WHO guidance there? And first of all, I really go back to what Saskia was saying at the beginning. We need to understand the multiple causes of anemia. Anemia is multifactorial. We're saying that half of it is nutritional. We don't really know that with certainty. And it's not necessarily only iron, it's iron. Folic acid, for example, is so important. But then there are other nutrients. But there are numerous other causes, and the infectious diseases, the environmental contamination, we are underestimating, and they are different in different countries. So we need to understand better the multiple causes of anemia with adequate diagnostic efforts. And that's the thing, we don't have good diagnostic capacity to make the differences. WHO is recommending, of course, to work through the health service with integrated delivery of services through antenatal care, but we need to question that. Antenatal care sometimes it reaches women, but not with anemia prevention programs. Iron folic acid supplements are not given to the women who are attending those services. And then we should actually have integrated services also with other conditions. I mean, why malaria programs do not support the treatment of anemia? Well, actually, we know that anemia is one of the most important causes of death as a result of anemia. Parasital disease programs. Now, this integrated delivery is important. And finally, food programs, food fortification, we need to find ways to reach the most difficult to reach and make sure that our fortification programs are not only delivered to cities and to those who have access to the market. So this is definitely a great idea, the alliance, and with the countries, I think we should be able to develop some good idea of an action plan and the way forward. Thank you.
Thank you very much, Francesco, for some very, very salient points. I'm glad you brought up the anemia exemplars. I believe that Mexico will be one of the countries that are highlighted. I think that is in process, so we're definitely going to be interested to see those as they come out. So can our 3 country representatives put their cameras back on? Richard, I see you there. Selene, okay, wonderful, excellent. Welcome back. So I think we now want to go into a little bit more detail about if and how you envision an alliance could support the efforts in the countries where you're working. And I think there's several different topics that we may want to focus on. Data and evidence, advocacy was mentioned, financing, and so forth. But I think I'm going to go in the same order, if you don't mind, and pick a couple of topics to speak to each of you. So let's go first to India. And can you tell us a little bit about if you envision a possibility for the Alliance supporting you around some of those data and evidence questions that may come up? Tell us a little bit about the need for data and evidence Is there a perceived need first for data and evidence? If so, do you envision that there could be a role and a support element coming from an alliance in that regard?
Yeah, thanks, Lynette. Absolutely pertinent question. Because although we have been having this program of anemia, as I said, for the past so many decades, we have a feeling that a large emphasis has always been on iron deficiency anemia, which may not be the only cause of anemia. So, and knowing anemia well, its multi-sectoral nature, there is a need to converge all the departments. And there, I believe it would require a lot of advocacy. Although we say even within the section of Ministry of Health and Family Welfare, there are separate departments for maternal health, separate department for child health, adolescent health, for prevention and control of hemoglobinopathies, for vector-borne control disease program, for fluorosis program, tuberculosis program. So there are n number of departments even within the ministry. So I think a lot of advocacy is required to bring all of them together. They are together, but there is no common thread which runs across all these departments as far as anemia prevention and management is concerned. So there, I think, I mean, it would be good to showcase and demonstrate through an implementation research how every department can be brought together. So that can be a good learning for all of us, I believe. The second need for evidence is about etiology. We have had some scattered and sporadic studies from all over India and over so many years now. It does mention that, okay, anemia is very heterogeneous in its nature and etiology, etc. But there is no comprehensive study which actually tells us what is the difference in the etiology in different states. All we have is a large-scale survey, which is NFHS, which only detects anemia. But it doesn't tell us how many of them are iron deficiency anemia, how many of them are dimorphic anemia. I know it's very difficult to attribute the cause of anemia because of the overlaps. But still, I think there is a need to generate evidence on the etiology of anemia, and it should be state specific so as to have context specific interventions in place. Then another thing is that there are several donors which are already working in India, several funding bodies, and they, with the help of government, they are instituting separate, interventions such as fortification. So it's very difficult to make out what part of the reduction in anemia could be attributed to that intervention. So that is another thing which I think we would be really interested in knowing. And besides that, some advocacy is required in terms of the cutoffs which are being used for assessing anemia. I mean, for example, if you look at the clinical guidelines, there and a cutoff of 11 is not considered as the cutoff based on which you decide whether a woman should be getting oral or IV or blood transfusion. But then when it comes to evaluation of anemia in terms of prevalence, it is always 11 grams per cent, which is taken as a cutoff. So we feel that there should be a uniform cutoff to measure the prevalence of anemia as well as to institute management guidelines. And there, I think we require a lot of, evidence is there. We need advocacy in terms of changing the cutoffs if you want to actually see the impact of anemia in the country. And lastly, it's about the diagnosis of anemia. As I said, that we have the point of care devices, but then we really do not know that if a woman is approaching a primary health care center with a hemoglobin of 8 grams per cent, if it is due to malaria or other things or dimorphic anemia. So to have those point of care devices at one place which can comprehensively diagnose the cause of anemia, that is something which is required. Things are there in place, but then we need to bring all of them together for management of anemia as well as for diagnosis of anemia. So these are broadly the research needs, which I think the Alliance should be able to cover or address.
Okay, thank you. That was really great. And I think a lot of your comments resonated quite strongly with some of the comments from Dr. Francesco Branca first, related to the needs around improved diagnostics, improved etiology responsive interventions. We actually have a question also in the chat from Kenneth asking about whether there are examples of countries that have developed more comprehensive anemia control programs and whether we have the results from those. And I think you highlighted spot on some of the challenges that we have in generating that evidence, because first of all, a lot of countries do not have comprehensive multi-dimension programs that have addressed simultaneously. And when you do, it's the more complex those programs, the more challenging to actually get at attribution of any changes to components of those programs and so forth. So there's a bit of a challenge there. And I think maybe there's a message we can send back to the exemplars that are pulling together this evidence to really grapple with that question and ensure that among the countries and the examples that they're of success they're looking at, that they really try to focus in on some that have addressed not only the nutritional causes of anemia, but others, and bring together that evidence of how we can do this and how we can increase both the potential for impact as well as the getting at that question of attribution and so forth. Okay, lots of other things, but I think we need to move on back to Mexico because we're going to run out of time. We're going to find this half hour quite short, I think. So in Mexico.
So going back into Spanish now, I would like to ask you specifically about the financing, because the program, and if I recall correctly, you mentioned, was financed primarily by the Mexican government through these conditional transfers that had all these different elements that you mentioned. So what could the Alliance do to support you now with the activities you are conducting at the Institute in order to reinstate these programs? What do you need? How could we or can we help you somehow so you can have the necessary funds to run these types of programs? Well, in Mexico, public budget is a very complex topic because it's organized in different ways. So there are autonomous bodies and powers that are given, and there are centralized institutions, federal bodies, direct budgetary control bodies, and so on. So what happens is that budgets are implemented by the receiving bodies who decide how to better use the resources they have. So different programs to support the nutrition of pregnant women, women in reproductive age, and young children have to have a very clear idea of how they're going to allocate and implement the budget they receive. So they need to have a very clear understanding of the minimum inputs and financial resources they need to implement their actions. What we believe is that the Alliance could be a great platform to receive advice and guidance on how we can secure this financing, but also continuity even if governments change. We also believe the Alliance could be a wonderful platform for advocacy to highlight the importance of having nutritional programs, deworming programs, as well as water security programs, not only to different government bodies, but also for civil society, especially with all the programs that we have to reduce anemia in women, as we said, pregnant, breastfeeding women, as well as young children. We also believe the Alliance could be a wonderful place to exchange lessons learned. We have from our program amazing lessons that we learned through the implementation of our different interventions, such as challenges to supply chain, as well as how to deliver the different actions. But we also learned a lot from the point of view of the beneficiaries. So in the case of Prospera, we identified that lots of women didn't know enough about supplements or had difficulties reaching health care centers or participating in the workshops that we had organized for them. And that these challenges had to do with their own jobs, the lack of childcare, or maybe long journey or difficulty accessing transport in order to reach the healthcare centers. So getting the help of the Alliance to compile all these lessons learned and then use them to design new programs to support nutrition in pregnant women and children would be great. Well, thank you. I saw that you already answered a question in our chat box, so thank you very much. And now, very quickly, are there any other actions related to anemia being implemented in other groups within Mexico's population? Because we know that Mexico has plenty of data related to the nutrition status of its population. So have you identified nutritional problems in other groups? Are there problems with anemia in other groups in Mexico? And if you have found them, have you considered implementing any other actions to support this? Problems related to anemia have been identified mainly in pregnant breastfeeding women and in general in women in reproductive age and children under 5. However, we have recently also found that teenage girls are having problems with anemia as well as older adults. And that's why all programs and policies are being geared towards the first 1,000 days of life, considering how important they are for the country's capital. And now with COVID, we understand that it's necessary to reinforce these actions. I mean, actions that are geared towards the entire population, but especially those for the first 1,000 days of life, as well as pregnant breastfeeding women and children under 24 months of age. So we understand that food security, as well as difficulties to access healthcare services, combined with the economic crisis that is affecting our country and the entire world, of course, is going to have a negative impact on nutrition and more especially on anemia in Mexico as well as in countries undergoing similar circumstances to ours. Well, thank you very much. We're going to go back to English now.
Yes, Richard. So I want to just pick up on the last point that Selene was making, which is about COVID, and tie that back to the point that Francesco Branca made about the importance of scale of activities. Tell us a little bit about what's happening in Kenya, just very briefly, what's happening in Kenya related to the continued scale of activities under the context right now of COVID. Is that something that you worry about?
Thank you very much, Lynette. I totally agree with Branca that we cannot achieve anything unless we are able to scale up interventions and they are able to reach the populations more in need, mostly those in hard to reach and rural places. COVID, as people might know, has caused, even though Africa is not the region that has been like affected as compared to other regions, but still COVID posed a lot of challenges in terms of provision of access as well as availability of services. Let me highlight a few. First is that with the health system that is struggling in terms of maybe human resources, both human and financial, had to be allocated for response to COVID. A number of health workers were reassigned to actually be taking care of COVID, and we had also seen that they were preparing for diagnostic, they are preparing for holding quarantine beds and things like that needed the resources. So it resulted in diversion of some of the resources into response into COVID. The second is fear. There was also fear from the general public about COVID, and knowing that most of the COVID cases are actually treated in health facilities and in communities. So we actually saw the number of mothers not going to facilities to seek care, or taking their children to facilities to seek care, and also movement of community health workers into communities and meeting people with physical distancing was another challenge. So, but what we have done as NI, and I think with the response, working closely with the government of Kenya, was actually to sit down with the government and actually say, nutrition is part of response to COVID. We know that if the population is well nourished, they will be able to actually fight off some of these infections. So yes, we were actually advocating for continued implementation of life-saving or essential nutrition services, including services for pregnant mothers and the like. So we have also been supporting government in ensuring that they have resources to be able to provide services without putting themselves at risk, as well as putting the clients also at risk, like procurement of protective PPEs. We've been supporting in terms of making sure that supplies, because of diversion of resources like iron and folic acid supplements, are available in the health services. We have also looked at supporting them to adopt use of technology. For example, we cannot continue to train by calling people to a place to train them. We have seen the issue about data collection, that there's need to adopt technology to be able to collect data and report. Yeah. We have also been working with helping government to how to bring the services closer to the community, right, as opposed to people coming to the facility. Thank you.
Yeah, very, very important. And I think that's one of the things that we can come back to related to the alliance, coming back to the topics of the lessons learned from the context to the to what might implications of the alliance be. I think that need for innovating in our monitoring and our data sources and using some digital approaches to some of that is very important as well. But you mentioned when you were completing your previous intervention that you had some reflections on how how the alliance could potentially be supportive to the actions in Kenya. So I would like to pass it over to you to tell us a little bit your reflections in that regard.
Yeah, I think first is I looked at issue of data and evidence. And in Kenya, data related to anemia control is collected and reported through routine district health information systems, and secondly, through surveys, namely the Kenya demographic surveys, national micronutrient surveys, malaria indicator surveys, food consumption surveys, to mention a few. And these surveys, basically, they look at the different determinants of anemia. They look at biochemical determinants, nutrition determinants of anemia, looking at non-nutritional causes of anemia, like the hemiplegia, and improved wash and coverage of related, and also genetic causes, more especially hemophilia. Are some of the things that are thought of. But looking at looking at the challenges that are faced in Kenya, there are issues about quality of data that is actually provided through the normal system or the district health systems. But when it comes to surveys, there is inadequate financing for surveys, which results in surveys being irregular and the quality being compromised because they don't have, there is no adequate resources to actually implement a proper survey which is quality assured. The third is that there is a lot of data that is being collected, but most of that data is not used for policy and decision making. And maybe that's the gap between people who collect the data and it's linked to universities and research. And there's a gap how all that massive data that is collected is actually influencing policy or is influencing decision making in terms of how to improve programs. So in that way, I looked at the need for country level for improved data, which are financing, mobilizing financial resources to support countries in conducting timely and quality surveys, building capacities for translating data into policy and decision making, and finally, data quality assurance to make sure that the services, the data that is collected, there is someone who is actually providing data quality assurance processes.
So
now,
can I just interrupt you? Do you mind if I interrupt you for a second? Sorry.
Please.
I want to dwell on this point just for a minute because I think it's very important. So am I hearing that one of the potential roles of the Alliance could then be supporting efforts in terms of models and experience and sort of reporting standards and sort of that technical support around the generation and use of data? Is that what I'm hearing as one of the potential gaps that perhaps this Alliance could be supporting?
Yeah, based on that, the analysis that I've given, I look at 3 areas as the role of Anemia Alliance. First is consolidating new program and technical evidence to share it with countries. Because sometimes people think they are doing the right thing. And therefore, if there is an alliance that is consolidating new programs and technical evidence and show what is working, what is not working, that will actually help countries in improving their responses to anemia, anemia challenges that they are facing. The second is collection and sharing of anemia data. At a global level, I think it's important to be able to collect and share anemia data. The third is actually global advocacy for building support for anemia action. Now, at the country level, there are certain lessons. I think as we are thinking of what is the role of Alliance to help at the country level, I think there are key lessons that I think the Alliance, they are relevant to the Alliance. First is to think, how do we actually interact with countries and the importance of country leadership and ownership of the program, which is rooted in deep trust and relationship building. We have noted that when we have like WHO, UNICEF, and SAN play the trusted global partner, it is easier to bring in new initiatives and actually implement those partners, those initiatives. The second is to customize programs to unique country contexts, finding the optimal mix of interventions based on a range of unique context features, bearing in mind that no one size fits all to address anemia. The other issue is multisectoral, because most of like Kenya and the other countries in the sub-Saharan Africa, they have actually adopted in the last 10 years, multisectoral work is what they know best, and they are trying to pursue with the multisectoral working.
Right.
To build that relation and co-create integrated work packages, it takes time.
Yeah.
So multisectoral anemia already exists across countries. It's not that they are not there. What is needed is implementation support to bring them to scale. And I think that's one of the things that we have actually learned, and you have, the Alliance have got to think about. And also,
I think we're gonna have to wrap it up. I don't want to cut short the comments from our final commentary, but I think you've brought up some really fantastic points around consolidating evidence, sharing anemia data, which I think is great to have that transparency, global advocacy, providing support around good practice of implementation and so forth. That's very important. And I did want to just bring back, we haven't had a lot of questions in the chat, but we do have a question from Omero Martinez, actually directed to India, but I'm just going to raise it because we don't have time anymore to answer it. But one of the important points that was raised here is related to accountability of within the national systems, all three were country-led. I mean, let's be very clear that the program in India is an Indian program. The program in Mexico is a Mexican program. And as you've said, the same in Kenya. And so I think these are really three great examples of those country-led strategies. But bringing in that question of accountability is really important. And I think perhaps that's something that we can continue our discussions in future moments and consultations. So I'm sorry to cut it short. It was a very great discussion. I would have loved to have time to go back to our other speakers as well. But I would like to now take the opportunity to introduce Ms. Aissatou Diallo. She is the Executive Director of Africa Catalyzing Action for Nutrition. She has served as Senior Nutrition and Partnership Advisor and Head of the Nutrition Program at the African Union, also in the New Partnership for Africa Development, NEPAD. She has also worked as Chief of Gender, Nutrition and Children at the United Nations World Food Program. And prior to that, she worked in her home country, the Gambia, where she established and served as the first Executive Director of the National Nutrition Agency. So we are very happy that you're here to provide some final thoughts and reflections on the Anemia Alliance. Welcome.
Thank you very much. And it is a pleasure for me to be here. And I'm just sorry you had to stop Richard, because he had so many great points and he even touched on most of the points I was supposed to, about to speak of. By the way, correction, at the World Food Program, I was Chief of Women, Children, and Gender, not nutrition, but I'm a diehard nutritionist. So having worked in the Gambia and especially on our anemia control program and experiencing the challenges, the frustrations of a national anemia program with the constraints that have been raised by other speakers here, the supply chain, logistics, and seeing the iron supplementation program being implemented year after year without much impact, I would say, because of various challenges which we were unable to address or didn't have the resources to address, I think makes this alliance, for me, a very important alliance and a very timely alliance, putting the focus, the shining the light on a global problem, and more specifically for the African continent. Now, a number of issues were raised there, some of which, of course, my esteemed colleague Richard already raised. But I want to re-emphasize the issue of data, which I always mention whenever I'm asked to speak about nutrition, the importance of data. Because this is about women and children. And I'm pleased to see that some of the countries are not just looking at pregnant and lactating women, but are looking along the life cycle, including adolescent girls and even adolescent boys and children of all ages and women of reproductive age. So the data is critical. And for me, that's the biggest challenge that the Alliance can take up, because we talk about that the voices of women are not heard, but I think the loudest voice for women would be the data, showing their situation, because the data is not just to show their situation, the data is for advocacy. The data is to enable the design of appropriate policies. The data is to advocate for funding. The data, most importantly, is to ensure action and to monitor action and also accountability. So for me, that's the most important thing that the Alliance should work on. And when we talk about data also, I know for years there's talk about building the capacities of countries. Data is being collected, but the quality of the data. And I think there was mention of quality assurance. So that is also an important point that the Alliance should really take on. Now, research is another thing, but I know there are some countries that have already mentioned that they're working with the academia and research institutions, and that is fantastic. Where you connect the practitioners with the academia and research institutions, but the research findings to be used for policies and action. So that is something also that the Alliance could work on with country partners, to ensure that there is that link and that the research findings are actually used for policies and action, and to monitor and also for accountability. I wanted to also bring up the issue of what works and what doesn't work. Because like, for example, the iron supplementation program, countries still continue to implement the iron supplementation program. What are the bottlenecks there? Why, if you have been implementing that for 40, 30 years, 20 years, why hasn't it been working? Why isn't it making much of an impact? So obviously, there are bottlenecks there that need to be identified and addressed. And of course, the multi-sectoral approach has been mentioned, and that is key. Another point is community engagement, because that is lacking. Community engagement. How can this Alliance be so inclusive as to put the communities in the center of the Alliance? So it just doesn't become a top-down approach with the Alliance there on top, working with countries. And, it has to, a lot of the effort has to come from the level of the countries. So investments as well. The investments would depend on the advocacy. How come for so many years we know anemia is a problem, is a challenge, and not a single country is on track to meet the 2025 goal? So why is it that in the countries most affected, especially where we have so many other problems, we have undernutrition, we have overnutrition, with diet-related non-communicable diseases, and where we have anemia as cross-cutting, because it's not just a problem for the underweight, but it can also be a problem for the overweight. So how come we still haven't reached the stage whereby it is taken as a priority, as a development issue? Sorry. As a development issue. So that is something that we also need to really ask the Alliance to establish as a priority. And we are talking about an inclusive alliance, because this is not just an alliance of organizations and people. It's an alliance of solutions. And in that, we have to be inclusive. And we know there's a lot of talk now, or it's been put on the table, about indigenous crops, indigenous fruits and vegetables, indigenous knowledge and practices. How can we be inclusive and look at possible solutions and encourage research and academia to look at other solutions outside of what we have been looking at, like having the usual fortification, which is critical, but and biofortification and all those other interventions. So that is also an issue that I would like to bring to the table. And of course, I think, yes.
I am very sorry, but it is time, and we would like Saskia to close before the.
Okay.
Because it is time that, and I hope that the participants will still stay 2 minutes with us.
Okay.
I mean, I'm very sorry, I'm interrupting you.
Okay, no problem. Thank you.
It was wonderful. Thank you. Saskia, I will give you the floor for the last couple of minutes for those participants that will stay with us.
Yes, thank you, Marty, and thanks so much to all the three panelists for your excellent contributions and sharing your lessons learned, and also sharing your ideas on how to further strengthen this alliance. And to you, Isatu, for your perfect summary of the discussions. And I know you were cut short, but I've written down 3 main points that I think we will really take along when we move forward. First is we have to think about accountability. Second is we have to be inclusive, both in the communities and in terms of engaging with the communities and making sure that we include communities in the alliance. And the third one is we have to be inclusive in terms of the solutions that we consider as part of the alliance. And I think there are very good examples also being shared on the benefits that the alliance can bring to national country programs, and definitely I think illustrating the need for a central platform to make sure that these lessons are being captured and are being learned. I just want to emphasize again that we do have the Exemplars Global Health Anemia research team also included in this alliance to make sure that there is this smooth integration of lessons learned from countries into both the global alliance, but more importantly into other country programs, so that we really make progress. Because I want to end here now with briefly summarizing the next steps. And that is, as I said, on July the 27th, there will be a affiliated session organized, and it will start at 7:30 Central European time as part of the pre-summit. If you can go to the pre-summit food system site, you can find the information and register for that session, where we will present the alliance as part of the larger cluster on women empowerment and leadership, and where we will also present a more updated form of the alliance, taking into account some of the lessons that were shared here today. Third, the alliance is open for new partners, particularly from countries, and also we will reach out to partners from other sectors. We are working towards the Food System Summit in September, where we aim to present already some official statements of support from countries for working through this alliance, and a more elaborated draft plan of action. And then finally, the Nutrition for Growth Summit in December, where we will officially launch the alliance with more details on the investment framework, taking into account how will this work. So with this, I would like to close this session. I would like to end with a quote, and we were chatting, we don't know anymore who made this quote, but I think it is one that is very relevant for this alliance. And that is if we continue to do what we did, we will end up receiving to get what we got. And what we got was a lack of progress in anemia. So in order to change that, we really need to start doing things differently. And I think this is a very, this session here today illustrates a very important first step from, hearing from 3 different countries, hearing their successes and their challenges, and what we really should be doing here together, because I think that's the other focus point. So I would like to thank all the speakers. I would like to thank Lynette for excellent moderation, Francesco for your comments in between the panels, and Isatu for your closing remarks, and then Marty for organizing this session. And with this, I would like to close the session, and I wish you a very nice day, and I hope to see you again on July the 27th. Thank you very much.
Gracias.
Thank you, everybody. You can contact us at the micronutrientforum.org.
Thank you.